post-COVID syndrome, our guidelines are, I think, around it was released before August last year. And following the first peak, we did have a lot of cases of post-COVID syndrome, but now we know that the second peak, the number of cases are much more than what happened following the first peak. So the number of cases of post-COVID syndrome are also going to be much more. And as Bipin sir said, every day we are having more and more different manifestations, the way in which the patients are presenting after apparent recovery from COVID-19. And over the last 6 months, the pathophysiology of post-COVID syndrome, etc., all these things have evolved. We're having new classification systems. So we thought that this time that we should have a repeat session, but regarding the management and all, much has not changed. So we should be more aware of the multitude of presentations as well as the pathophysiology of post-COVID syndrome. So why the title I have put it as ongoing COVID syndrome? Because post-COVID means what we are trying to convey is that COVID is over, and then what is happening after that is something which is not related to the virus per se. But then we know that the COVID does trigger an inflammatory as well as a dysregulated immune response, and the manifestations can actually range from say days of onset of the disease to actually months after onset of disease. So now the current terminology is more likely to be it is an ongoing COVID syndrome, because we don't know the real trigger, but still it is an ongoing process. And the objectives of this session will be to discuss about the various ongoing COVID syndromes and the current evidence regarding the pathophysiology as well as the management perspective, to discuss the various clinical presentation of post-COVID syndrome and to identify the red flag signs. As far as the state is concerned, we are more focused on identifying the red flag signs, and to discuss about the rehabilitation considerations. So all the videos following the first training session, which was conducted around 6 months back regarding the pulmonary rehabilitation, all the videos are available in the state's training sessions on the YouTube link and all. Now, the basic question is with regard to what should be the right terminology. So we know that initially we used to term it as the long COVID syndrome. This term was actually coined by the patients themselves in WhatsApp groups, and those patients who recovered. So they sort of said that the symptoms are lingering for a long period of time. So they coined the term long COVID syndrome. And then the terminology was like this post-acute COVID syndrome. That is, people who are having these lingering symptoms after apparent recovery from an acute COVID-19 infection. And then recently following the NICE guidelines which are released in December, now the appropriate term is likely to be an ongoing COVID syndrome. Now, coming to the initial definition, that is, after the symptoms are persisting for say 21 days, they used to be termed as the post-acute COVID-19. And then the symptoms are actually persisting for more than, persisting beyond 3 months. They used to be termed as chronic COVID-19. That is, after 21 days, the term was post-acute COVID-19. And after 3 months, if the symptoms are persisting, it is the chronic COVID-19. And then, regarding the percentage of patients who are likely to develop this post-acute COVID-19 and chronic COVID-19. So it actually depends on what sort of patients you are studying. Suppose you are doing this study in an ICU population, probably almost 100% will be having say post-COVID syndrome. Suppose you are conducting this study in say healthcare workers, who are having only say mild disease severity, probably say around 10% will be having the post-acute COVID-19 syndrome, and probably around say 2% will be having the chronic COVID syndrome. So actually it varies. It varies depending on the subset of patients that we are planning to study. The pathophysiology of post-COVID syndrome with its multi-system manifestations actually is not clearly understood, but it's supposed to be due to a persistent low-level inflammation or lapsing inflammation due to an dysregulated immune response. And one thing we should keep in mind. So now we know that we are not advising. So on the 10th day we used to do the RAT for mild as well as moderate cases. Now we have actually done away with that, because now doing the RAT testing on day 10 used to give a false sense of security to the patients, because patients think that once their RAT is negative, they're out of danger, but it's actually not so. For 96% of the patients in Kerala, they require just, they are forced into the mild disorder or the category A. So mild disease severity, majority of them are 40% asymptomatic, and the rest we having only mild symptoms. They just require this monitoring to see whether they will progress to the category B, C, that is to moderate or severe disease. They do not require any therapeutic intervention. What they require is actually rest at home as well as constant monitoring using the pulse oximeter as well as a 6-minute walk test, and to identify the red flag signs. Okay. So they don't require this RAT to know whether they are out of danger, nothing like that. So we are actually focused on the rest 4%, whose disease are likely to progress after, say, the first week or so. That is when the cytokine storm or the inflammatory response is likely to set in. So this is something which we should know. So even doctors have a false sense of derive a false sense of security by doing the rat test. So this conveys a wrong message, because the rat may be negative. Rat is actually a marker of infectivity alone. So it does not say whether the patient is likely to go into cytokine storm or things like that. So we should do away with our reliance on this rat testing and thinking that once the rat is negative, the patient is going to be out of danger. Okay, instead we should be paying more attention to the red flag signs. So this is actually from the WHO chart, which says that for mild disease, usually the recovery occurs by around, say, 14 days. Whereas for severe disease, the recovery takes around 3 to 6 weeks. So basically, in those with severe disease, the disease will be progressive. The thing is that even for recovery, 6 weeks might be required. And this is one definition all of us must be familiar with. This is from the NICE guidelines, which is released in December 2020. We just look at the definition. Acute COVID-19 is signs and symptoms of COVID-19 up to 4 weeks. That is, now once you are symptomatic, up to 1 month, whatever is happening is actually referred to as acute COVID-19. It is not post-COVID syndrome. So once we used to describe, so whatever is happening to the patient after the rat is negative on day 10, we used to term it as the post-COVID. It is not like that. Up to 1 month, it is acute COVID-19. If the symptoms are persisting from 1 month to 3 months after symptom onset, it is termed as ongoing symptomatic COVID-19. So post-COVID-19 is referred to those patients whose symptoms are lingering or persisting after 3 months from the symptom onset. So all three will together be termed as ongoing COVID syndromes. There is acute COVID-19, that is up to 1 month. There is the ongoing symptomatic COVID-19, that is from 1 to 3 months, and post-COVID syndrome is symptoms lingering after 3 months. So now when we look at the pathophysiology, so why the symptoms are lingering for longer periods of time? So you have the virus-related factors, the virus-specific pathophysiological changes. It could be due to the immunological aberrations and inflammatory damage. We know that during the first week we are having the viral replication. It sets in motion, inflammatory, sometimes a dysregulated immunological as well as inflammatory response due to the pro-inflammatory cytokines. And this can actually damage multiple organ systems. And the symptoms which are related to this dysregulated immune response can persist for longer periods of time. And we have the classical sequelae of the post-critical illness or post-intensive care illness. That is, any patient who are getting into ICU due to any illness. It need not be due to COVID-19. So definitely they take a longer period of time to recover, what is referred to as the post-critical illness syndrome. So this is from a recent article in Nature, which looked at the timeline of post-COVID-19 syndrome. You can see that, so whatever has been discussed is captured into a beautiful graph. You can see that you have the week 3, week 4, and the week 12. That is in 3 months. After 3 months, you're terming it as post-COVID syndrome. And these are the usual symptoms which are likely to persist for longer periods of time. That is fatigability, decline in quality of life, muscular weakness, joint pain, dyspnea, cough, the persistent oxygen requirement, then the psychosocial issues like anxiety, depression, post-traumatic stress disorder, palpitations, chest pain, thromboembolism, chronic kidney disease, hair loss, etc. So the most important aspect is that by the end of the 10 days in case of mild to moderate disease, and by 15-20 days, your antigen is going to become negative. This is very, very important. So all these things are going to occur after that. So we should not be paying that much attention to the antigen negativity. And this is what the pathophysiology in short, it will be like this. The first week you are going to have this viral replication. And in a subset of patients, that is around, say, 4%, you are going to have this immune dysregulation. Then you're having this endotheliitis or intussusceptive endotheliitis, as the ACE2 receptor is present in the endothelium as well. And this can result in activation of coagulation cascade leading to the micro as well as macrovascular thrombosis. And there was a recent study from Yale University, which used a platform known as the Rptcr platform, which looked at the autoantibodies against the self-antigens. So they checked simultaneously the antibodies against 2,500 self-antigens. They found that in those with post-COVID syndrome, diverse functional autoantibodies were persisting in those with post-COVID syndrome. So this is actually the pathophysiology behind why some patients are going to progress to this post-COVID syndrome and why some patients will be having lingering symptoms. So this chart everyone will be familiar with. This is a very old chart, but this actually shows the distribution of the ACE2 receptor and what to expect in patients in the in COVID-19. No, maybe say after apparent recovery. So we need to be looking at these sort of complications. As Vipin sir said, one patient did present with a loss of vision after apparent recovery. So that could be due to this optic neuritis. It can also be due to a central retinal artery or a venous occlusion. So we should be aware of all these possibilities. We know that thromboembolism can occur actually, say, at any time after apparent recovery from COVID-19. It is due to the presence of the activation of the coagulation cascade, as well as endotheliitis due to presence of ACE2 receptor. So patients can present with deep vein thrombosis, can present with pulmonary embolism, can have arterial venous ischemia, stroke syndrome, myocardial infarction, mesenteric ischemia, and all those things. And when you look at the cardiac system, the patients may develop this stress-induced cardiomyopathy, which is referred to as the Takotsubo cardiomyopathy. Patient can have myocarditis, cardiac arrhythmias, cardiogenic shock, myocardial ischemia, acute core pulmonale, and autonomic dysfunction syndrome, which is often referred to as the POTS, that is the postural orthostatic tachycardia syndrome. That is, those patients who have recovered from COVID-19 also sometimes will have a sudden onset of palpitation with sweating, especially while standing for longer periods of time. It is actually a reflection of autoimmune dysfunction. All these things will recover by itself, but might take weeks to months in certain individuals. When we are looking at the endocrine axis, it has been in the spotlight because of the COVID-associated mucormycosis and who's of the unholy trinity which leads to COVID-associated mucormycosis. The most important aspect is the uncontrolled blood sugar levels. It's due to the presence of the ACE2 receptor as well as the TMPR resistor. There's a co-receptor in the beta cells. Also due to during cytokine storm, there is insulin resistance as well. So because of these reasons, you can have new onset of diabetes in COVID-19, as well as in those patients who have been having diabetes mellitus, you can have uncontrolled blood sugar levels and patient can progress to diabetic ketoacidosis. So the endocrine manifestations are actually not limited to diabetes. The patients can have subacute thyroiditis, which can manifest as hypothyroidism as well as hyperthyroidism, can have Addison's disease, which might be due to the use of steroids as well. Then when we look at the skin dermatological aspect, around 20% will be having this hair loss, which is telogen effluvium, and also all sorts of rash has been described in COVID-19. So it could be a maculopapular rash. You can also have these bullous lesions or chickenpox-like lesions in following COVID-19. And we know that the ACE2 receptor is present in the blood-brain barrier, and we can have all sorts of neurological manifestations. So we can have the anosmia due to the peeling off of the olfactory epithelium. You can have the dysgeusia as well as ageusia. You can have all sorts of stroke syndrome. You can have the Guillain-Barré syndrome, transverse myelitis, etc. So when you look at the renal axis, you can have the tubular damage as well as the proximal tubular dysfunction. You can have acute kidney injury, which is usually self-limiting. In those with from African descent, due to the presence of APOL1 gene, you can have something akin to this HIV HIV-associated nephropathy. You can have in COVID, there is Covert, there's COVID-associated nephropathy. And when we look at the hepatobiliary system, you can have transaminitis, and sometimes that may persist for longer periods of time. Another important aspect as far as GI symptoms is concerned is that you can have this diarrhea which can persist for longer periods of time, and you can have the shedding of the virus through feces. You can have the fecal shedding of the virus, which may persist for more than 11 days after the nasopharyngeal shedding has come down, and this virus can also trigger this irritable bowel syndrome. So we need to be aware of the multitude of manifestations which can encompass all the systems in the body when you are dealing with the post-COVID syndrome. So this is actually this is the first study to look at the way in which the patients might present after COVID-19. You can see that around 30% will be having impaired concentration, 30% will be having sleep disorders, something referred to as COVID insomnia. An interesting aspect that we have observed is that this the sleep disturbance usually starts after the second week. So during the active infection, majority may not be having this loss of sleep, but usually after apparent recovery, they may lose sleep around 30%, something referred to as COVID insomnia. Then memory loss in 34%. All these things will improve by itself. Exertional dyspnea in 42%, and by far the majority are likely to have excessive fatigability. And this is our own data from our institution. Excessive fatigability in our 60%. Most important thing is that the study was done in healthcare workers, means that majority of them had only mild symptoms. Even in those with mild symptoms, excessive fatigability after 21 days was observed in 60%. exertional breathlessness in 30%, altered sleep rhythm in 24%, excessive hair loss in 20%, myalgia in 15%, headache in 15%. Headache means that no, this can actually trigger off the migraine. Vascular headache can be triggered off by COVID-19 infection. We can have polyarthralgia, polyarthritis. We can have the brain fogging, which is otherwise referred to as executive dysfunction. So patients may not be having, may appear disoriented even weeks to months after recovery. That is referred to as brain fogging or brain fading. Then anxiety as well as depression. Now, this is actually data from the largest study on the post-COVID symptoms. This is from the Wuhan registry. So they looked at around, say, 2,300 patients and they categorized them into three groups. Three groups means one group which did not require oxygen, second group which required oxygen but not NIV or on ventilator, and the third group which required NIV as well as high flow nasal oxygen. So they actually followed up these patients for 6 months. And what they found is that majority of the patients did have fatigability or persisting sleep disturbance even after 6 months. So, and obviously those patients who were severely ill during hospital stay, their symptoms did persist for longer periods of time, including their abnormalities in the diffusion capacity, the abnormal CT images. All these things did persist for longer periods of time, naturally in patients who were in ventilator or required NIV. So from this study, after 6 months, and 63% had excess fatigability, 26% had sleep disturbance, 22% had hair loss, the anosmia and parosmia persisted 11%, palpitation 9%, and arthralgia 9%. So this is sort of a representation of symptoms which persisted even after 6 months. There's palpitation, smell disorder. So the thing is that the anosmia and all, for some majority, it will recover within the first week or second week itself. But for some, it can persist for weeks to months. So this shows that more than 10% this anosmia did persist for more than 6 months. And this olfactory epithelium has the peeled off, and when there is a regeneration of the olfactory epithelium, you can have this altered sensation of smell perception like parosmia and all. Then hair loss, anxiety, sleep disturbance, dyspnea, and by far the most important thing is the excessive fatigability or say chronic fatigue syndrome like thing. This following the Epstein-Barr viral infection, there is something which is referred to as the chronic fatigue syndrome. So if the fatigability is persisting for more than 6 months, you call it chronic fatigue syndrome. So definitely the study shows that COVID-19 can also lead to this chronic fatigue syndrome. And we know that following the SARS in 2003 and MERS in 2012 also, a subset of patients did have these lingering symptoms which persisted for months to years. Some patients, around 20% had excessive fatigability even say 3 years after recovery in case of SARS. So this is with regard to the alterations in the lung function as well as the CT images. So you have divided them into three categories. One category which did not require supplemental oxygen, the second category which required supplemental oxygen, and the third category which required NIV or invasive mechanical ventilation. So you see that when you look at the DLC, which is less than 18% predicted in the first group, 22% abnormality persisted after 6 months. In the second group, 29%, and in the ventilated group which required HFNO or NIV, 56% had abnormal diffusion capacity even after 6 months of recovery. So when you look at the CT imaging, there's the persistence of ground glass opacities. So you can see that around say 45% did of the study subjects did have this persisting ground glass opacities even 6 months after recovery. And the irregular lines, that's what you probably reflect as the fibrosis and all. So it's present in 11%, 15%, and 24% after recovery even after 6 months. So basically, I will try to encapsulate what we have discussed. It is a post-COVID syndrome is a multisystem characterized by multisystem involvement in the cardiovascular system. So we should pay attention to symptoms like palpitation, chest pain, which might reflect myocarditis, cardiomyopathy, and cardiac failure. The respiratory system patients can develop lung fibrosis, then pulmonary artery hypertension, as well as pulmonary embolism. Nervous system patients might present with anosmia, the stroke syndrome, the short-term memory loss, reduced attention span, confusion, poor quality of sleep, cognitive impairment, and cognitive blunting, which we refer to as brain fogging. So the mental health aspects are also very important. We know patients can present with anxiety, depression, PTSD, and sleep disturbance, and the musculoskeletal aspect also very, very important. Polyarthralgia, polyarthritis, myalgia, and excessive fatigability, and the chronic fatigue syndrome. And some patients can present with a very interesting symptomatology, like say the neuralgic pain-like things. If they are complaining of arthralgia, some patients after recovery may complain of post-herpetic neuralgia-like thing. This is due to the presence of the ACE2 receptors in the dorsal root ganglia. So because of the presence of these ACE2 receptors in dorsal root ganglia, some patients can present with neuralgic symptoms and some patients can present with autonomic neuropathy. And we need to understand that all these symptoms can occur during the after recovery from the patient as well. And we know that the early sign of infection is anosmia, dysgeusia, and to an extent chemesthesis. So chemesthesis means the ability to perceive the chemical sensation by the taste buds. Chemical sensation means the flavor of the mint and all. So those who have had, majority of us would have had this COVID at one point of time. So we know that when we are losing taste, we are not losing the perception to of all the taste together. So first thing to be lost is the perception of the chemical sensation. There's a mint flavor. And whatever we have discussed can be put as 4 clinical syndromes. One is the classical post-critical illness syndrome. That is any patient in the ICU, so they will take a longer period to recover, and it is not this specific to COVID-19. So following any infection, if the patient is in the ICU, so there is likely to be a critical illness myopathy as well as critical illness neuropathy, and also there is going to be a deconditioning of all the muscles, including the diaphragmatic muscles, and it takes a longer period of time to recover. And second is the post-viral fatigue syndrome, which is actually described with other viruses also. The third is a lasting organ damage, like suppose the patient is having bronchopneumonia, and sometimes the patient subset can progress to pulmonary artery hypertension as well as fibrosis. And fourth is the most interesting thing, there is a fluctuating symptoms with slow recovery. That is, patients might be complaining of polyarthralgia for 2 or 3 days, and after that patient may complain of migraine, excessive fatigability, etc. All these things are described in COVID-19. So this is why this post-intensive care syndrome is occurring in COVID-19. The pathophysiology is actually same as that is occurring with the post-intensive care syndrome due to other infections as well. So there is microvascular ischemia as well as injury, and there is immobility as well as metabolic alterations, and obviously there is a secondary bacterial and fungal infections. And we know that when we are taking care of patients in the ICU, so after second week or so, it is the time when you are going to get these healthcare associated infections, which need not be a drug-resistant bacterial infections. It could be the fungal infections like say candidemia. It could be COVID-associated pulmonary aspergillosis or COVID-associated mucormycosis, and this is triggered not only by it's not only the healthcare perspective. It's a breaches in the infection control or breaches in antibiotics stewardship. Due to the drugs that we are using to treat COVID-19, that we are using the immunomodulators, etc. That is to save the patient, but then there is other side to it. These all the steroids as well as the tocilizumab or baricitinib, all these drugs are double-edged swords, and in certain patients, they can can lead to candidemia or sepsis. So we need to keep these things in mind. And the thing is that we have experience with COVID-19 only for 1.5 months, 1.5 years now. But then the SARS as well as MERS also did lead to this sort of lingering symptoms. And one study in SARS showed that 40% of people who have recovered from SARS still had chronic fatigue symptoms even 3.5 years after being diagnosed. It's very, very important, because if you're having these fatigue syndromes persisting for longer periods of time, it will definitely going to hamper your work capacity. You are going to become depressed, and we need to extend rehabilitation measures to all these patients. And the most important aspect is those who are recovered from COVID-19 pneumonia, there is a possibility that these patients may progress to fibrosis, and that is the importance of having the pulmonary rehabilitation. So this is, so following COVID bronchopneumonia, you can have this post-COVID interstitial lung disease, and this is the mechanism. So because the ACE2 receptors will get downregulated, there is an increase in the angiotensin 2 level, which will lead to the increased synthesis of the transforming growth factor beta, which can lead to extracellular matrix accumulation as well as myofibroblast activation, and this can lead to fibrosis. But does that mean that all the patients are going to progress to this PCILD? No. These are the risk factors for lung fibrosis. One is definitely advanced age, as was evidenced by studies on SARS as well as MERS. Second is definitely the increase in disease severity. Third is prolonged ICU stay and duration of ventilation. And fourth is actually smokers are 1.4 times more likely to have severe disease or symptoms of COVID-19. And they are 2.4 times more likely to require ICU admission and mechanical ventilation. So definitely they are likely to progress to the fibrosis. more than others. So this is actually the natural history of post-COVID fibrosis. The most important thing is that the drug which is likely to prevent the progression to fibrosis is the judicious use of steroids. But now we know that in many centers we are using these antifibrotic agents like pirfenidone or nintedanib, which is even not backed by enough evidence. So when you look at the natural history of post-COVID fibrosis, we can see that in around say 80% it will be improving. So without any other intervention than the steroids that we are using for treatment of COVID-19, so this the patients will improve by its own, and it might remain static in a certain subset of patients, and less than 5% it may continue to be progressive. So if there is evidence of progressive fibrosis in serial CTs, and if there is evidence of hypoxia requiring oxygen supplementation, and if this fibrosis is progressing despite the appropriate use of steroids, it is in this group that antifibrotics may have a role. But then the jury is still not yet out on this, whether the nintedanib or pirfenidone is really helpful in the setting of COVID-19. There is not enough data. And if there is any evidence, we have to restrict the use of this antifibrotics to the third group, which comprises less than 5% of the patient population. That is, those with progressive fibrosis, those requiring supplemental oxygen, those who are having fibrosis, progressive fibrosis despite the optimal use of steroids. And the next aspect is we have discussed about what can happen to the lung and the patients who are likely to progress to coronary artery hypertension, as well as those patients who are likely to progress to fibrosis. The heart is also affected as part of the post-COVID symptomatology. And this is one interesting study which was published in the American Journal of JSCC, which actually looked at the prevalence of myocardial and pericardial involvement in college student athletes recovering from COVID-19. Obviously, so in college student athletes means that they would have had this asymptomatic or mildly symptomatic infection only. So if you look at that, in the asymptomatic, the patient group itself, 12.5% had pericardial involvement and 6.25% had myopericardial involvement. So when we looked at the symptomatic group, the involvement of the myocarditis was around 16.7%. So if you look at the entire group together, around 27.1% had pericardial involvement, myocardial involvement is 16%, and myopericardial involvement 12.5%. So how did they do this study? Because now those with exertional dyspnea and all, we are doing this echocardiography and all, but then echo is absolutely normal. This study was actually done because they are having only subtle abnormalities in the pericardium as well as the myocardium, so which may not be picked up by the usual echo modality. So this study was done using gadolinium enhancement cardiac MRI, and they used a modality of echo which is referred to as the speckle tracing echo. So this is very important, means that even in asymptomatic individuals, there is a possibility that maybe around 6% will be having this myocarditis. This is a very, very important thing. So that is why we say that even in those with mild symptoms or who are asymptomatic, we want them to be we don't want them to be performing, say, heavy strenuous activity for, say, next 2 to 3 weeks. This is very, very important. So what usually happens is that majority of asymptomatics, they go out and get this rat testing done by, say, around day 10 or so, and when they get this negative result, they feel that they are totally out of the disease, and then probably they might resume the activities from day 11 onwards, and this is going to be pretty detrimental, can lead to tachycardia and all. And many young patients have actually collapsed on day 11 and 12 because of this. So we need to keep this in mind. Even those with mild disease, they may be having this myopericarditis, so they may not require any aggressive treatment intervention. The only thing is they will require rest. And the message we can convey is that even those with mild symptoms, we should ask them to resume their usual level of exertions only after, say, 2 to 3 weeks. And this aspect also has to be tackled. We had sessions on multisystem inflammatory syndrome in children. That is, I think last week we had a session on MISC. So this actually can be counted as a post-COVID complication, because usually it is after 25 days that of a mild COVID-19 infection or an asymptomatic COVID-19 infection that you're going to have this multisystem inflammatory syndrome in children. So MISC up to 21 years, the patient is presenting with these sort of features, it will be termed as MISC. And after 21 years, it will be termed as MISA. Almost all the pediatricians are they are aware of MISC. That is why the mortality as far as the MISC is concerned in Kerala is actually pretty low. The internationally 2.5% is the mortality in MISC, but in Kerala the mortality due to MISC is pretty low because all the pediatricians are aware of that. But when you look at the physicians per se, all the physicians are not aware of the entity known as multisystem inflammatory syndrome in adults, because now in adults we are having a broad differentials for the presentation. For example, I will take you through this case. A 23-year-old male, present with fever, fatigability of 3 days duration, and patient had a transaminitis as well as acute kidney injury. Patient present with a BP of 90, 60, and saturation was also low, and was diagnosed with myocarditis, and COVID antigen as well as PCR was done, just negative. We take you through the labs. Total count was 25,000. Neutrophilic predominance, thrombocytopenia was there. The CRP was elevated. The D-dimer was very much elevated. CRP was initially 2.6, but then it rapidly rose over the next few days. The ferritin was more than 10,000. Procalcitonin was more than 100. And if you do have access to IL-6, IL-6 also will be very much elevated. So the thing is that a patient, 23-year-old immunocompetent, is presenting with a shock syndrome and with the neutrophilia. So the first diagnosis obviously is going to be septic shock. But then other things like a wheel syndrome, etc., should also be kept in mind. So we did the tropical fever workup, which was negative, the blood culture sterile, the echo, there was no variation. So these are the possibilities to be considered in all these sort of manifestations. One is the tropical fever syndrome, like say leptospirosis or strep typhus infection, the septic shock, infective endocarditis, and MISA. The why I want to focus on MISA is that usually the thing is, so we know that in the second wave, the zero prevalence study, if you're doing, it is going to be pretty high. So I think maybe around 40% of our population would have been exposed to the infection by now. So we know that if 3,500 children are affected, so one kid is likely to develop MISC. The same thing we don't know about adults. For getting one case of multisystem inflammatory syndrome in adults, how many adults need to be infected, we don't know. But the thing is that as the number of cases of COVID-19 goes up, the chance of patients who are likely to present to us with MISA is also likely to go up. So we need to keep MISA as one of the DDs of any patient who is coming to us with hypotension with neutrophilia. And this is the pathophysiology of MISC as well as MISA. The most important thing is that the COVID-19 infection, which triggers of this thing, might be innocuous. The patient may be having a mild COVID-19 or an asymptomatic COVID-19 infection. So that is the importance of taking asking leading questions, whether so 3 weeks back, you had a high-risk contact with COVID-19. So whether any of the family members were infected with COVID-19. So are you in a locality where COVID-19 is very much prevalent like that? We know that entire Kerala is very much prevalent. So asking such questions may not be proper now. So that is why I said that we need to keep our both eyes open to picking up the manifestations of MISA. So what it does is that following a mild SARS-CoV-2 infection, which may or may not be recognized, this the virus can act as a super antigen and can trigger off the T cell as well as the B cell responses. There is a hyperimmune response, and the patient can present with multi-system manifestations, which include mental irritation, mucosal inflammation. Patient may present with rash. The hallmark is likely to be myocarditis and the sparing of the lung. The patient is listening not because of pneumonia. The patient is listening because of myocarditis and cardiac failure. In children, you can have the coronary aneurysms. Usually, they present with abdominal pain and diarrhea. And when you're doing an ultrasound, you may see an appendicular inflammation may be there, the mesenteric nodes may be there, pericholecystic edema may be there. So you should not be misled by all these things. So even if there is if you say that there is a tenderness over the McBurney's point, if you can conclusively rule out a perforated appendix or something like that, and all the markers are very much elevated, need to keep MISC also in mind. Mesenteric adenitis, ileitis, colitis, etc. So this is the working definition of the MISA. Any patient who less than 21 years, you call it as MISC, or more than 21 years, you call it as MISA. Any patient with severe illness requiring hospitalization with a positive test which points towards a recent or a previous SARS-CoV-2 infection, the antigen or PCR may not be positive. Usually we rely on antibody tests, and there should be evidence of SARS-CoV-2 infection within the last 12 weeks. Sometimes the antibody also may be negative. So in 30%, you may not be able to identify a relation to a recent SARS-CoV-2 infection. Severe dysfunction of one or more of extrapulmonary organ systems. Patient may present hypotension due to myocarditis. then arterial venous thrombosis or acute liver injury. And usually the markers of inflammation are going to be very much elevated, like CRP, ferritin, and D-dimer. Procalcitonin. So in that case also you had neutrophilia. The patient did present in shock, and procalcitonin, which we take as a specific marker for bacterial infection, the levels are very much elevated. But we should keep one thing in mind: procalcitonin is also an inflammatory mediator. So in MISO also the procalcitonin levels may be very much elevated. And the most important thing is what differentiates multisystem inflammatory syndrome from a severe COVID-19 is going to be the lack of involvement of the lung. And usually in severe COVID-19, you have a severe bronchopneumonia, and you have the hypoxic damage which affects all other organ systems, and that is why you're going to have more. Whereas in this thing, MISA, the bronchopneumonia is not going to be predominant. Instead, the patient is dyspneic because of myocarditis. The most difficult aspect as far as an adult is concerned is that it is a diagnosis of exclusion. So means that you need to rule out septic shock, you need to rule out all the tropical fever syndromes, you need to rule out endocarditis, you need to rule out autoimmune conditions like SLE, vasculitis, and all. So, but then we need to we should not spend that much time ruling out all other differentials, because if the patient is presenting you with myocarditis and shock, at the earliest, you need to load the patient with 1.5 milligram, 1.5 gram of methylprednisolone, followed by 1 gram of methylprednisolone for 3 to 5 days, and then go for the steroid taper. This is very, very important. So that means that if you want to rule out all these differentials at the earliest, you need to keep this MISA as one of the differentials for any patient who is going to present to you with abdominal pain, high-grade fever with abdominal pain and diarrhea, in whom all the inflammatory markers are very much elevated, are going to have a neutrophilia, leukocytosis, and the patient is in hypotension due to myocarditis. So if someone is presenting like this, always keep the possibility of MISA in mind. This was one of our cases who presented with acute abdomen, and there was tenderness, and the patient was in shock, and the initial diagnosis was probably in acute abdomen, and patient is in gram-negative shock, and laparotomy was done, and this is what you saw. The terminal ileum is thickened, but then the diagnosis turned out to be a multisystem inflammatory syndrome. The patient was in ventilator, and once we clinched the diagnosis of multisystem inflammatory syndrome, the patient was started on high dose of steroids, and we could wean the patient of ventilator. That's the most important thing. Suppose you are not diagnosing MISA, the patient is going to die. That is why, for over all the atypical manifestations, we need to keep MISA as one of the diagnoses, one of the differentials. And next aspect is, the patients after the discharge is likely to come back or develop this thrombotic events like pulmonary embolism, myocardial infarction, DVT, mesenteric ischemia, and all those things. And all of you are very much familiar with this chart from our treatment protocol and the pathophysiology COVID-associated coagulopathy. These are some of the images: the patient presenting with arterial ischemia, patient presenting with central retinal artery occlusion, etc. So the patient is complaining of blurring of vision or painless loss of vision. So the DDs you need to think is CRAO, CRVO, as well as Bibin sir did mention, optic neuritis as well. And then the most important aspect is should we since post-discharge thromboembolic complications are a reality in COVID-19, should we be discharging all the patients, all the hospitalized patients on thromboprophylaxis with apixaban or rivaroxaban? So that is actually not recommended. So we need to handpick those patients who are likely to develop arterial or venous thrombosis after discharge. So this also you are familiar, is based on the IMPROVE VT score. If the score is more than or equal to 4, you need to send them home on apixaban or rivaroxaban for say 2 to 3 weeks. The score is more than or equal to 2, and if the D-dimer level is more than 2 times the upper limit of normal, also you can discharge the patient on apixaban or rivaroxaban. Other patients should not be sent home on oral anticoagulants. And I'm not going to focus much on these things. That is the patients maybe 2 weeks into the ICU stay, they are not still improving. The patient is developing fever and pleuritic chest pain, and the CT is repeated, and the nodular cavitating lesions are there. We need to think about COVID-associated pulmonary aspergillosis as well as the reactivation of TB, because for treatment of COVID-19, we are using steroids as well as immunomodulators like tocilizumab and baricitinib, which can lead to the reactivation of tuberculosis, can also lead to infections like nocardia, can also lead to COVID-associated pulmonary aspergillosis, and we know that is the COVID-associated mucormycosis. So mucormycosis need not be rhino-orbitocerebral mucormycosis always. It could be pulmonary mucormycosis also. We did have extensive sessions on how to differentiate between the kappa as well as mucormycosis. I'm not going to spend much time on that. Now, coming to the treatment of the ongoing COVID syndromes, so most important thing is those patients who require supplemental oxygen definitely will require pulmonary rehabilitation, as well as nutritional rehabilitation and psychosocial rehabilitation. Regarding the role of antifibrotics, we did discuss, so there is no concrete evidence to say that so pirfenidone or nintedanib is likely to reverse the fibrosis in those patients with COVID-19 induced ILD. The most important aspect is that all the case series have shown that after 3 months or so, there is a reversal even without this antifibrotic agent. So even if you are contemplating using these agents, it should be restricted to that 5% where there is a progressive fibrosis with hypoxia, which is not improving despite optimal use of steroids. Regarding anticoagulants, so there are two situations where you need to continue anticoagulation after discharge. So one is if the patient was diagnosed to have diagnosed or suspected to have pulmonary embolism or DVT. In such situation, you need to continue this anticoagulation for 3 to 6 months. Second is if the patient's improve VT score is more than 4, as we have discussed. And fourth is the cardiac failure. So patients who have been diagnosed with the post-COVID cardiac failure, definitely the treatment for cardiac failure has to be initiated. Now, the most perplexing and most difficult to treat is going to be the chronic fatigue syndrome. That is, and the chronic fatigue syndrome, we don't have evidence to suggest the use of omega-3 fatty acids or vitamin D or vitamin E. So, most important aspect is that these are the drugs which are usually used. There is no harm in using these drugs, even though it's not backed by evidence, except vitamin D in those patients with hypovitaminosis D. Some patients will be having vascular headache, and then those patients should be started on medication for vascular headache. And some patients will be having this post-herpetic neuralgia like pain. For them, the treatment for neuralgic pain has to be initiated. One aspect is that those patients who are off the ICU, so there is going to be catabolic muscle wasting, feeding difficulties, and frailty. So malnutrition is there in say 26 to 45%. So we need to assess the nutrition status, swallowing function, as well as functional independence. So along with pulmonary rehabilitation, so those who have been in the ICU, we need to optimize the nutrition rehabilitation also for the best possible outcomes. And this is the one important thing, the sleep hygiene. As far as rehabilitation goes, so around 30% do have COVID insomnia. So we should aim for at least 7 hours of sleep. So it is very easy to say that. So we need to exercise during daytime, avoid caffeine in the afternoon, avoid alcohol, and avoid blue light exposure 1 hour prior to bedtime. So aim to go to bed at same time each night and avoid afternoon naps. So despite all these non-pharmacological interventions, if now COVID insomnia persists, and that is the time where you need to start the patient on, say, solpidem or melatonin and drugs like that. And then we need to identify the reversible causes of fatigability. This is very, very important. So patients who are complaining of excessive fatigability after recovery, so you need to see whether there are reversible causes like hypothyroidism. This I'm saying that because COVID-19 triggers of a dysregulated immune response. So this can result in autoimmune manifestations like thyroiditis. So thyroiditis, which can manifest just like hypothyroidism in some patients, even they can manifest as hyperthyroidism. So we have had cases of Hashimoto's thyroiditis triggered by COVID-19. We have cases of Graves' disease triggered by COVID-19 like that. All these things are described. So patient may be on say 50 micrograms of L-throxine, and suppose patient is having excessive fatigability after recovery from COVID-19. You have a relook at the TSH as well as the T3 and T4. Sometimes the recurrent might have gone up. So this is a reversible cause of fatigability. The second one is hypoadrenalism. This is very important. It's not due to adrenalitis per se. Probably it could be due to the use of steroids in COVID-19. It's very important. Sometimes we will be using anti-fungal drugs like say itraconazole or voriconazole or say posaconazole or isoconazole. All these things can lead to hypoadrenalism. We should keep a lookout for diagnosis of hypoadrenalism in patients with excessive fatigability. Another interesting aspect is this obstructive sleep apnea. So in those patients with obstructive sleep apnea, so we observed that this apnea-hypopnea index, which is actually a surrogate marker for the extent to which this obstructive sleep apnea is going to be a problem for the patient. So after COVID-19, there is the muscle dysynchrony like sort of thing, a deconditioning of the respiratory muscles as well as the diaphragmatic muscles, and it can lead to a worsening of the obstructive sleep apnea. So suppose the patient is complaining of excessive fatigability during sleep, You need to see whether there is an issue with snoring and all. And suppose you are getting close to a obstructive sleep apnea, so get a sleep study done, and probably by using CPAP at night, etc., the excessive fatigability can be corrected. And then hypovitaminosis D is also as a correctable thing that you need to look out for. And this is actually from the state guidelines. So we do have the telemedicine platform for risk stratification to avoid crowding in post-COVID clinics. We know that if you look at fatigability per se, so majority of the patients might be having a post-COVID fatigability. We don't want all these patients to be coming to our the clinics. So we are having a 3-tier clinic system. So the first tier in the PHC, FHC, and CHC, the second tier in the district hospitals, and third tier in the general hospital as well as the medical colleges. And thanks to Bibin sir, we are having a well-oiled this the referral system across the state, and we are having say 1,200 to 300 post-COVID clinics. So the aim of these clinics is to identify the red flag signs at the earliest and go for a tier-based referral system. The red flag signs are the dyspnea, palpitation, chest pain, unilateral pedal edema, and syncope. And the patient will be assessed in the primary first level centers, and if needed, so based on the differentials they entertain, will be sent to the secondary as well as the tertiary care centers. So the most important red flag sign obviously is going to be the exertional dyspnea, where the DDs are going to be anemia or respiratory cause like fibrosis or embolism, and cardiology cause like myocarditis, LV systolic or diastolic dysfunction, cardiomyopathy. So if such a patient is coming to the primary care center, so we need to have these DDs in mind. We need to rule them out one by one. Do a hemogram. If you do have access to CRP, D-dimer, do that. So D-dimer is to see whether the patient needs workup for pulmonary embolism. So PFT, X-ray chest, HRCT, echo, these will be done. If you think that the patient requires further evaluation, should be sent to second and third tier centers to do all these investigations. If D-dimer is elevated, probably you may have to do the CTPA to rule out pulmonary embolism. So if all the investigations are normal and still the patient is complaining of exertional dyspnea, that is when you must think about cardiac fibrosis or say a subtle pericarditis, where even echo may not be able to pick it up. So that is a situation where you need to consider cardiac MRI or nuclear scintigraphy. So this is actually from the recent Nature article on how to manage the post-COVID patients, those who are presenting with dyspnea or those who require persistent oxygen requirement after discharge. So we need to monitor them using the 6-minute walk test at home. So do periodic PFT, X-ray, the workup for pulmonary embolism, echo, HRCT if indicated. Most important another aspect is the neuropsychiatric screening for anxiety, depression, PTSD, sleep disturbance, as well as cognitive impairment. So when you look at the hematology axis, so the thing is that you need to handpick those patients who are going to benefit from thromboprophylaxis. Okay, so we need not start this thromboprophylaxis for all the discharge patients. We need to identify those patients based on the modified VT score and start them on NOACs at the earliest. Those with acute kidney injury, so definitely you need to fix up a follow-up with the nephrologist. In all cases, acute kidney injury do recover. These things we need to be very careful about. And one interesting aspect is that those who have recovered from COVID-19, we know that they can take vaccine 3 months after recovery. So what is going to happen to the post-COVID symptoms if you are offering vaccine to this patient? So since the symptoms have got an autoimmune etiology, so we believe that one of the mechanisms of pathophysiological hallmarks of the post-COVID syndrome is actually the persistent autoantibodies. So what will happen if you're offering this vaccination to these patients? Will this autoantibody mediated symptoms worsen, or will it somehow recover? So the largest survey to date on vaccinated people with long COVID showed that 57% of respondents reported an overall improvement in their symptoms following vaccination, while 19% reported an overall deterioration. So what it means is that definitely the patients are likely to improve. The long COVID symptoms like fatigability, polyarthralgia, etc. might improve following COVID vaccination. And this is another interesting thing. There is the Asia syndrome. Asia syndrome is autoimmune, autoinflammatory syndrome induced by adjuvants. Okay, adjuvants is what you have in the vaccine, but this trigger need not be the adjuvant. It could be an infection per se. So I will take you through the major criteria as well as minor criteria, and probably you'll be able to relate to the patients you might have seen over the last months. Like the major criteria is an exposure to an external stimulus. It need not be an adjuvant. It could be an infection. That is SARS-CoV-2 infection could be the trigger. And the appearance of typical clinical manifestations like myalgia, myositis, muscle weakness, arthralgia, arthritis, chronic fatigue syndrome, unrefreshing sleep, sleep disturbance, neurological manifestations, cognitive impairment, pyrexia, dry mouth. And once you and typical biopsy may not be needed in our cases. The minor criteria is the presence of autoantibodies or a specific HLA like HLA DRB1, HLA DQB1, etc. So in order to diagnose this Asia syndrome, there must be at least two major criteria or one major and two minor criteria. So we might have seen many patients after COVID-19 complaining of this the myalgia or arthralgia persisting long periods of time with elevated ESR and all. So this actually shows that probably all these things might fit into a diagnosis of an autoimmune, autoinflammatory syndrome which can be triggered by an infection. And that is why majority of these patients do respond to a short course of steroids. So thank you very much for patiently listening. So we have a very robust post-COVID clinic setting in the community, but as Bipin sir did say, we are having more and more bizarre manifestations day by day. So if you keep the pathophysiology of COVID-19 post-COVID syndrome in mind, we'll be able to identify all these, the post-COVID manifestations at the earliest and probably go with a proper referral plan. Thank you very much.
NT-proBNP useful in detecting myocarditis?
NT-proBNP is actually a marker of cardiac function. So elevated NT-proBNP can be taken as a surrogate marker for LV systolic dysfunction. So can be used as a marker for myocarditis.
We have seen prolonged antigen positivity up to 1 month in patients who are asymptomatic. In one case of MISC with RAT positivity after 1 month of first positivity. RAT positivity means infectivity is the question. Whether
actually usually we take PCR. We say that the prolonged RNA shedding can lead to prolonged PCR positivity. But the same thing we don't say about antigen, because the only state in the world which might have done antigen testing for long periods of time would be Kerala, and we have seen many cases where antigen has been positive for I think I have seen for up to 40 days, even in asymptomatic individuals. And one mechanism is it need not be infectivity per se. So protein shedding can also lead to antigen positivity. But having said that, in immunocompromised individuals, like post-transplant HIV patients, to an extent in pregnancy and all, the period of infectivity need not be 20 days. You can have even the live virus shedding going for longer periods of time. So that is not actually this persistent antigen positivity occurs only in a very small fraction of patients. It is not the norm.
We need to give steroids in post-COVID patients presenting with pneumonia.
Post-COVID patients presenting with pneumonia, we need to identify the cause of pneumonia, because it could be anything, from bacterial, it could be fungal pneumonia, it could even be PCP, because some patients who have been received steroids, and when there is worsening of the lung function, the oxygen requirements are worsening, and you are taking a CT, and there is ground glassing, it could be PCP also, pneumocystis pneumonia, because once you are using steroids and tocilizumab, etc., you're drying off your T-cell mediated immunity, you can have all sorts of manifestations. So you need to think about all these infections. Only after that, you need to think about steroids. Okay.
An out-of-context questions, COVID patient with leukocytosis and neutrophils and lymphopenia on 1 dose of steroid and on high dose of steroids. How can we confidently say if it is due to steroid or secondary bacterial infection?
Actually, it's a very difficult question, and that is the reason why you are having that much of an antibiotic misuse going on in a hospital. One thing we should keep in mind, that is following H1N1, and the incidence of secondary bacterial infection following H1N1 is actually far more than the incidence of bacterial infections following COVID-19. We know that on whichever patient we start steroids, there is going to be lymphopenia as well as neutropenia, and total count is going to go up. So we need to look for other markers of infection, like say patient is developing fever or patient is developing say leukocytosis, if there is a fall in saturation like that. If you do have access to procalcitonin, and procalcitonin can be used as a marker rather than going behind the increasing total count. Another thing is that suppose you want to start an antibiotic, you send all the cultures. No, once the patient is on steroids, I agree that fever may not be a very good marker to identify infection. But then make it a habit to send the blood cultures, the urine cultures, as well as the ET aspirate or sputum cultures prior to starting antibiotics. Because broad spectrum antibiotics are going to be a huge problem.
Should we keep all such patients under antibiotic?
No, definitely not. Definitely not. We need to identify those patients who are going to get infection and only then treat such patients. Because the thing is that we are using steroids for other conditions as well. No, we are not monitoring the total count. Again, we are not starting them on antibiotics. What we do is we go by the clinical presentation. No? So we never treat the counts, treat the patient.
Can we give low molecular weight heparin for 3 weeks post-COVID?
There are situations where you may have to give low molecular weight for 3 weeks, like say pregnancy and all. So pregnancy and all, if there is a increased risk of thromboembolism, we can't use NOACs. In such situations, you can go for a low molecular weight heparin. Other situations, you can switch over to NOACs.
Is there any chance for an individual to show Rptcr test positive immediately after vaccination?
I know that you are asking this question based on your personal experience, but then all the literature says that since the vaccines are not containing live virus, you cannot have an RT-PCR positivity following vaccination. That's not possible, but we have seen many cases where the patients have become RT-PCR as well as antigen positivity after getting the vaccine. One explanation could be that healthcare workers, we do have the risk of getting asymptomatic infection at any point of time, and we may not be knowing that. Once we are taking vaccine, we are triggering our immune response. Okay, so we are going to become symptomatic. So probably we have been having this asymptomatic, we have been having this virus. We are taking the vaccine, and once we take the vaccine, there is our immune system has been triggered off. It's like kicking our immune system into action, and definitely it may overreact against the virus, and we are going to likely to become antigen or PCR positivity. Otherwise, technically, a vaccine cannot lead to RT-PCR or antigen positivity.
Any role for physiotherapy following COVID?
Definitely. Pulmonary rehabilitation is the one which is going to make a difference regarding the outcome of patients who are on NIV or ventilator.
Cancer surgery in post-COVID, any specific things to be taken care of? When can we take up for surgery? Should we be giving therapeutic dose of anticoagulation in all? Any other prophylactic measures to be done?
So when can surgery be?
Cancer surgery.
Cancer surgery. Actually, I think we have answered this question in the previous sessions as well. So cancer surgery depends on the emergency nature of the surgery. Suppose you are having an elective surgery. So American College of Anesthesia recommendation is to postpone the surgery by say 1.5 to 2 months. After that, you take the elective surgery. Suppose it is an emergency surgery, there is no contraindication as such for an emergency surgery. Regarding the need for anticoagulation, it has to be on a case-by-case basis to go by anticoagulation. So, and the important thing is that suppose the D-dimer levels are elevated, cancer in by itself is a risk factor for itself means that the VT score is going to be high, and such patients should be on thromboprophylaxis. And if you are going to take the patient for an emergency surgery, ideally the patient should be on thromboprophylaxis.
I have seen at least two cases in which fever, headache, etc. following vaccine went to become COVID positive. That is actually explained just now. Sir, a patient has nocturnal desaturation to 90%, even 2 months after severe COVID pneumonia, hypothyroid on 50 microgram of TF on thyroxine. TFT is normal and resting awake. SpO2 on post 6-minute walk test. SpO2 weak. Please give your expert opinion on the possible cause of line of management.
Yeah, this is what I referred to. The nocturnal desaturation is an unrecognized entity. So see whether the patient is having obstructive sleep apnea. So do a sleep study and look at the apnea-hypopnea index. Okay, this is actually a reversible cause of fatigability as well as just by CPAP at night, the patient's quality of life is going to improve like anything.
How to treat post-COVID splenic infarct?
How to treat post-COVID splenic infarct, right? Okay. The splenic infarct means you need to look at what is causing this splenic infarct. Okay. What is the cause of this splenic infarct? Sometimes the splenic infarct could be secondary to infective endocarditis, which is not very common following COVID-19. So it could be due to an embolism from somewhere else. You need to identify the cause of this infarct and treat. Otherwise, treatment per se for splenic infarct is not there. We identify the predisposing factor and treat that. And an important thing is that we need to be sure it is splenic infarct, because imaging wise the abscesses may mimic the splenic infarct, and if you are having a splenic abscess or a hepatic abscess, you need to think about fungal infections like candidemia as well, especially in patients who are received tocilizumab.
Please explain how to pulmonary rehab. I think you will get videos from...
Yeah. Pulmonary rehabilitation, we have beautiful videos by Dr. Manu in the DHS site. You go through all those videos. Okay.
How to manage dermatitis, vesicular rash in post-COVID patients?
In dermatology, as such, you can have all sorts of manifestations. Definitely, it is going to be symptomatic. I cannot say what is to be given for dermatitis, vesicular rash, etc. We need to keep this in mind. So, any patient who is presenting with these manifestations, it could be COVID also. In Trivandrum, we are having an outbreak of chikungunya and some exanthematous fever also. So now we have a very broad differentials for fever with rash. So it could be chikungunya, it could be dengue, it could be some other exanthematous fever like infectious mononucleosis. It could be COVID as well. Only thing is you need to keep this DD in mind also, COVID-19. And if the patient is pretty sick, it could be MISC or MISA. This also will manifest with rash.
Sir, is there any role of IV immunoglobulins in MISA?
Actually, MISC, there is a role for IV immunoglobulin. Recently, we had an NEGM article which compared 3 arms. The immunoglobulin alone arm, then the immunoglobulin plus methylprednisolone arm, and then the methylprednisolone alone arm. Okay, so what they found is with IVIG alone, there is a sort of a the therapeutic outcome was not optimal. So definitely you require IVIG plus methylprednisolone. But the experience from Kerala, as far as the pediatricians are concerned, the outcomes with the methylprednisolone is pretty good. Okay, so what we do is we start with methylprednisolone. If the outcome is not optimal, then we switch over to IVIG. So our outcomes with the methylprednisolone high dose is actually very, very good. We use this thing for sort of a salvage, IVIG for sort of salvage if the response to methylprednisolone is not optimal.
Why is lung spared in MISA?
Actually, I don't know the reason. It's very lucky that lung is spared. So otherwise, we won't be having any clue to do how to diagnose this MISA. The exact reason I don't know why the lung is spared. Lung is spared does not mean that the lung is totally spared. You may have some ground glassing in the lung, some sort of a lung infection, but then that cannot account for the what is happening in the extrapulmonary. In the other organs, it cannot be explained by what is happening in the lung. That is why we are saying that in MISA the lung is spared. Whereas in severe COVID-19, the lung will be CT severity index, etc., is going to be pretty high, more than 15. And because of the subtle cellular level hypoxia, other organs are getting involved. Whereas in MISA, it is not like that. MISC and MISA, the lung involvement is going to be minimal only. The exact reason, I don't know.
It's safe to do this walk test without a cardiac evaluation?
Actually, 6-minute walk test, there are certain contraindications, especially for a 6-minute walk test. What we are saying is that it should be done at your own pace, just like walking in your own room. We are not asking them to walk briskly and all. There is another 6-minute walk test where we are asking them to walk for the maximum at the maximum pace for the maximum the distance they are covering. So our 6-minute walk test is not like that. You need to walk at your own pace. Still, there are contraindications to 6-minute walk test, like those patients who are having, say, a previous exertional angina or cardiomyopathy, cardiac failure, etc. These are contraindication. Pregnancy is a relative contraindication. Elderly, maybe above 65 years also, we don't want a 6-minute walk test to be done.
Can we start aspirin in high-risk individuals on home isolation?
Actually, the recovery trial, the aspirin arm, the results are out. There is no benefit in doing so.
How to treat decreased sleep in post, that sir has already told, but
decreased sleep, I think we go with the non-pharmacological interventions which are not likely to work, but still try that. And if it is not working, go with solpidem plus melatonin combination. Okay, or seek the help of a psychiatrist.
any antiplatelets?
Okay, antiplatelets. We are always talking about this anticoagulants, because if you look at the pathophysiology of COVID-induced coagulation, the problem is the alterations in thing is von Willebrand factor levels expression is going to be more, and there is an Adams 13 deficiency. These sort of things cannot be addressed by antiplatelets like ecosprin or clopidogrel. That is why we insist on heparin or say NOAX. Okay, and you should go through the recovery trial, the aspirin arm, which did not show any mortality benefit in those patients who are allotted to the aspirin group. That is why we are not using it.
CDC recommends COVID vaccine to be administered after an interval of 90 days in case of MAB use or convalescent plasma for COVID.
Yeah.
Please provide the rationale. The session was very useful and informative.
Okay. Actually, the monoclonal, now the convalescent plasma is out of the national guidelines. The convalescent plasma is not being used. We are talking about the casirivimab plus imdivimab. So basically, the casirivimab and imdivimab are actually monoclonal antibodies which are going to attach to the spike protein S1 as well as S2, and which will prevent the binding of the spike to the ACE2 receptors. Okay, the thing is that when we are using a passive antibody sort of thing, we are not very sure about how our adaptive immunity or the T cells as well as the B cells are going to respond to a vaccine trigger, and that is why the gap of 3 months is kept.
What is the appropriate time for PFT after COVID negativity? How should COVID negativity be assessed?
Actually, there is no appropriate time when a PFT is being done. What usually we do is that those patients who have been had COVID pneumonia, who required HFNO, NIV, or say oxygen. So we want a pulmonology follow-up, usually from the institution from where they get discharged. So the pulmonologist will decide when the PFT has to be done. And sometimes if the patient is on steroids, etc., probably the PFT will have to be repeated at a later date. And regarding when the CT is to be repeated, etc., also we leave it to the pulmonologist. Okay.
Sir, in post-COVID lung fibrosis, when the patient is fit for discharge, do you recommend a gradual tapering of steroids over a course of 1 month, or do you recommend discharge without steroid?
Actually, what we do is usual recommended the duration of steroid is 7 to 10 days. But we know in practice, even after 10 days, if the patient is requiring oxygen, if there is evidence of inflammation, we actually go for a gradual taper. But is that gradual taper to be done over 7 days or 1 month? We individualized. For some patients it will be over 1 month. For some patients we taper over 7 days. Okay.
No.
So basically, our aim must be to use the lowest possible dose of steroids with which the patient outcomes can be optimized. Okay, especially in the setting of diabetes and all. You know that post-COVID diabetes plus steroids, it will be very difficult to control the blood sugar levels, and we are having problems like COVID associated mucormycosis. So try to use the lowest possible dose of steroids, which can quell the pulmonary inflammation.
What is the treatment of post-COVID neuralgia?
Post-COVID neuralgia. So important thing is that if you are having say 90 patients with arthralgia, 10 patients will be having neuralgia. Identify those 10 patients who present with neuralgic symptoms and start them on gabapentin or pregabalin.
A person who got COVID positive after first dose of vaccine, when should we give the second dose vaccine? 3 to 2 months after COVID infection?
3 months after recovery.
Okay. 3 months after recovery. Recovery post-COVID also.
Yeah. Well, not from long COVID. 3 months after recovery from acute COVID. Okay.
A lot of patient comes with complaints of gastritis post-COVID lasting for more than 6 months.
Gastritis lasting for more than 6 months. Actually, we need to address why this is occurring. So we need definitely a gastroenterology consultation. See what all drugs the patient received while the patient was in the hospital, like steroids and all. It can trigger of ulcer and all, and it can also lead to irritable bowel syndrome. That is the most interesting thing. One of the as a part of diverse autoantibody development. One thing which was mentioned is that inflammatory bowel disease as well as irritable bowel syndrome can be one of the manifestations of the post-COVID. You can have IBS, which could be irritable bowel syndrome or inflammatory bowel disease. You require a proper gastro evaluation. And there is an alteration of the gut microbiome also due to this COVID-19 as well as due to the use of the broad-spectrum antibiotic. The dysbiosis can occur, and this can lead to persisting gastrointestinal symptoms.
What about the interval between 2 Covishield vaccines? That actually there is an administrative guideline. So
we know the guideline, so no issues now.
Can we give Alprax for post-COVID insomnia?
Alprax, I believe that can lead to more dependence than Solpadol. Okay. So if you want to use it for say 5 days or so, it is fine.
Out of context question, many people are developing only low antibody levels after vaccine. Any thoughts on that?
So basically, the thing is that now what is going to prevent the severe disease is the T cell mediated immunity. Okay, so T cell mediated immunity, we cannot measure the T cell mediated immunity. So you need not be worried about the low antibody levels. And recent studies have shown that what we are measuring probably is going to be the anti-spike antibodies. Okay, so anti-spike antibodies does not really correlate with the neutralizing antibodies, which we are not measuring. So none of our labs can measure the neutralizing antibody levels. So suppose your spike antibody levels are low, probably the proportion of neutralizing antibodies may be more. So you will get protection. And the most important aspect of this vaccination is actually not to prevent infection from occurring. It's actually to prevent hospitalization and severe disease and death. Definitely all the vaccines are capable of doing that. Because in order to prevent a severe disease from occurring, what you require is 1/6 of the neutralizing antibody level to prevent an infection from occurring. Okay, so all these vaccines will be generating enough neutralizing antibodies, which will be 1/6 of the neutralizing antibody required to prevent an infection. So severe disease and death can be prevented by almost all the vaccines.
Is there any guideline to start antibiotic in the clinical course of COVID? No.
The most important thing is that don't treat the counts. Okay, there is one thing which we want to convey. Don't go after the total count, because neutrophilia will be there as a part of COVID-19. We know neutrophilia will worsen, so the number of neutrophils will increase once we are using steroids, because it will lead to lymphopenia. So, and the increasing total count, increasing neutrophilia alone should not be taken as an indication for starting antibiotics. So once, if you want to start an antibiotics, clinically there should be an evidence of infection, like say a new onset of fever with say a purulent secretion like that, or say the patient is complaining of dysuria, something like that. So try to identify the cause of fever. Okay, send the appropriate cultures. Start antibiotics. If the cultures are turning out to be sterile, you should stop the antibiotics also. Okay. And regarding the use of antibiotics to prevent secondary infection, antibiotics cannot prevent secondary infection. What antibiotics can really do is it can lead to a secondary infection with a drug-resistant organism. Please keep that in mind.
Aspergillosis and mucormycosis are only attributable to steroid, or can it be attributed to COVID only? I mean, is it the only steroid?
No, definitely not steroids. Because we have been using steroids for other disease conditions for long periods of time. It's truly multifactorial. So one thing we need to keep in mind is that usually the COVID-associated pulmonary aspergillosis is seen only in critically ill. Okay, those in the ICU, those requiring HFNO, NIV, like that. Only in that category we are seeing COVID-associated pulmonary aspergillosis, and we know that following influenza also we had something which is known as IAPA, as influenza-associated pulmonary aspergillosis. So what happens is that following a viral pneumonia, so you are in the mucosal immunity, that is the tracheobronchial tree, the mucociliary clearance, as well as alveolar macrophages, everything, etc., may be sort of they're functionally they may not be up to the mark like that. So you are having this aspergillus spores everywhere in the ICU as well as the environment. So usually a normal person will inhale around 200 spores of Aspergillus fumigatus every day. And what prevents us from getting the infection is our mucociliary clearance as well as the alveolar macrophages and all. And in following a post-influenza or a post-COVID pneumonia, so these mechanisms will be defective, and we are at risk of developing a pulmonary aspergillosis, COVID-associated pulmonary aspergillosis, or influenza-associated pulmonary aspergillosis. So this could be triggered by the use of steroids, tocilizumab, etc. So the most important thing is that the steroid use per se is not the reason. The reason is multifactorial, and it has something to do with the infection control practices in the ICU, etc. And that is why, if you have a habit of doing the spore count for aspergillus, etc., it might work. Regarding mucormycosis, the situation is a bit different, because you know that the Holy Trinity, the unholy Trinity responsible for development of COVID-associated mucormycosis is: one is COVID-19 infection per se, second is uncontrolled diabetes, third is steroids. But unlike COVID-associated pulmonary aspergillosis, the severity of COVID-19 does not have any relation to development of mucormycosis. We are having mucormycosis even in patients who never had severe COVID-19. That is the basic difference between aspergillosis and COVID-19. So please don't blame steroids for this thing. Steroid is one of the factors, and probably the most important thing is, even if you are using steroids, if you are able to control the blood sugar levels, I don't think then mucor may be a major problem.
Sir, excuse
Go
me, sir,
ahead.
I have a doubt. Sir, you had told that this duration of 90 days is after monoclonal antibody uses for casirivimab and intivimab. Does it apply for tocili as well?
No. Tocilizumab, the mechanism is entirely different. No, so when the US FDA spoke about these monoclonal antibodies, they were not referring to tocilizumab. Tocilizumab is a humanized monoclonal antibody against the IL-6 receptor, so it has nothing to do with this vaccination. That you can use, no problem.
Sir, in that case, what should be the minimum duration?
The thing is that following a COVID-19 infection per se, you can give it only after 3 months. So the both aspects is taken care of.
Okay, sir. Thank you.
Sir, I have a doubt. So after vaccination, many labs are doing antibody titers. There is a 0.8 is the cutoff value and all. If it is not neutralizing antibody, a high value doesn't offer any protection.
It might give a false sense of security, sir. That's it. So because the thing is, one is the labs may not be having the standardized technique. We cannot measure the neutralizing antibody titers. So that is another thing. And suppose if it is an immune escape variant, these antibodies are not going to protect you. So only thing we need to keep is we need to vaccinate everyone, so that even if you are getting infection, it will be a mild infection only. Or against Delta plus and all, it is sort of an immune escape, because it has the K417N. That is what the South African variant also have. So even if you are having neutralizing antibody, you might get infection, but you are not going to get severe disease. So there is no point in that. Is why CDC, all the authorities, all the guidelines say that you should not do an antibody testing prior to vaccination or after vaccination.
Yes. Sir, suppose if I treat a patient with the category B with IV steroids, and the patient gets better and is sent home, and after 2 weeks the patient comes back with fever, desaturation, X-rays shows pneumonia, and if you do the CT, it comes as COVID, post-COVID pneumonia, like there are ground glassing. So can we give IV steroids again for the second time? Is it okay?
Yes, sir. Actually, the second time, definitely the patient might require IV steroids, but the first time it was not indicated, because category B, there is no hypoxia. Okay, that is one thing. So we should reserve steroids for those patients with hypoxia or exertional desaturation. Definitely, the second time around, patient should be treated with steroids.
But if the category B patient was desaturating, is it okay?
Sir, that is the thing, sir. If the category B patient is desaturating, the patient is category C now. Okay.
Sir, one doubt. Hello?
Yes.
I can hear you. Go on.
Sir, there is no doubt that steroids are beneficial in the management of COVID. But what is your opinion on tocilizumab? Because I feel that it can cause severe immunosuppression and predispose the patient to secondary infections.
The thing is that tocilizumab is a very, very, very useful drug. Okay. The thing is, we don't have that much drugs with mortality benefit in COVID-19. The drugs with mortality benefit, at least in RCTs, are one is steroids, to an extent the prophylactic dose of anticoagulants, the tocilizumab, and the monoclonal antibody in the recovery trial. But in the recovery trial, the dose of monoclonal antibody used is 4 grams. And here in India, the approved is 600 milligrams of Kesari plus 600 milligrams this thing. So tocilizumab does have a mortality benefit. The most important thing is that tocilizumab should be used there is only a very the therapeutic window of opportunity for using tocilizumab is actually 24 to 48 hours of worsening. So if you look at the previous guideline is the one which we had in April 2020 and August 2020. We were saying that CRS, cytokine release syndrome 3 or 4 is the indication for starting tocilizumab. By that time, it would have been very late, and during the first wave, our experience with tocilizumab was not very good. But then following the remap cap trial, now the indication for using tocilizumab is a bit more earlier. That is, the patient is requiring, say, HFNO, that is the FaO2 0.4 30 liters per minute. and if the patient is not improving in say 24 hours despite optimal use of steroids, that is the situation when you should be using tocilizumab. That is actually very early. That is, the patient is on oxygen, say 30 liters per minute, 0.4 FiO2 on HFN or NIV, and you are using steroids for 24 hours, there is no improvement, and that is the indication for using tocilizumab. Or the second aspect is, say the CRP is more than 75 and the patient is not improving on steroids. So that is a bit more earlier use of tocilizumab, and if you are using tocilizumab at that point of time, actually the outcomes are actually good in our experience during the second wave. But having said that, we are using tocilizumab because we don't have other drugs which might actually prevent the the progression to the ventilation and all those things. Once you are using tocilizumab, we should keep one thing in mind: the chance of bacterial sepsis is actually 2 times that of the control group. The chance of candidemia is there. The chance of occurring the other, even cryptococcal meningitis have been reported. So you can have the COVID-associated pulmonary aspergillosis. All those things we should keep in mind.
Sir, may I ask some questions in between before somebody else chips in? Sir, one question is, should we include all the symptoms that is coming after COVID into this post-COVID syndrome? That is one question we got.
Focus on the red flag signs. Okay.
Okay. Second question is, sir, patient with RAT RT-PCR negative, HRCT shows CORADS 5, CT score is 15. Should we treat the patient as COVID or post-COVID?
Actually, it is COVID only, because the state guidelines do clearly mention that this is an entity which is referred to as RT-PCR negative SARS-CoV-2 infection, and we need to treat as COVID. Okay.
So, is there any upper limit of steroid-induced leukocytosis above which secondary bacterial infection is more likely?
I don't know. The thing is that you please don't go behind the counts. You assess the patient clinically and treat. Okay. And once you are starting IV antibiotics, broad spectrum antibiotics, prior to that, please do send the cultures. And if the cultures are sterile and procal is negative, you should de-escalate or stop the antibiotics.